Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Rebecca Sapp. I'm a board-certified allergist and immunologist and a fellowship director who always enjoys learning more about the exciting field of allergy and immunology. Our podcast series will use interviews with thought leaders from the world of allergy and immunology to keep up to date on new developments and to review core topics. We are pleased to welcome Dr. Allison Ramsey and Dr. Carolyn Wang for today's episode of Conversations from the World of Allergy podcast. Today, we're going to focus on the topic of contrast hypersensitivity, focusing on immediate reactions to iodinated contrast. Dr. Ramsey is an allergist and clinical immunologist at Rochester Regional Health and an assistant professor at University of Rochester School of Medicine. She is the former chair of the QuadAI Adverse Reactions to Biologics and Latex Committee. Dr. Wang is a professor in the Department of Radiology at the University of Washington, as well as the medical director of imaging at the Fred Hutchinson Cancer Center. Dr. Ramsey and Dr. Wang recently co-chaired a task force of allergists and radiologists on hypersensitivity reactions to iodinated contrast media. The recommendations from this group are soon to be published in the Journal of Allergy and Clinical Immunology and Practice, as well as Radiology, and I thought this was a great opportunity to hear about the most up-to-date thinking about contrast allergy and its management. And in full disclosure, I was actually on the task force, and I learned so much from everyone involved that I wanted a chance to talk with them. Dr. Wang and Dr. Ramsey, thank you so much for taking the time to join us today.
Thank you for having us.
Thank you for having us.
Do you mind if I call you Carolyn and Allison?
No, of course. Feel free.
Please do.
I'd just like to start by getting to know you a little bit better. Carolyn, can you tell us a little bit about yourself and maybe include something you like to do outside of medicine?
I'm Carolyn, and I am not only a professor of radiology at the University of Washington, but I also am the current chair of the ACR Committee on Drugs and Contrast Media. Outside of radiology and work, I enjoy watching K-dramas that started with the pandemic and has continued onward, and skiing with my family whenever I can get outdoors.
Wait, which K-drama is your favorite?
Well, right now I'm watching Buried Heart, which is on Hulu, but my favorite is probably Happiness, which is on Netflix, which is a kind of a zombie apocalyptic thriller / romance thing.
I watched Crash Landing on You. That was what actually one of my residents recommended I watch, and I really enjoyed it. So maybe I should give those a try.
For the doctor world, I do recommend Dr. Slump too. That's also on Netflix if you want.
Oh,
it's like at the stress and burnout related to medicine.
That sounds great.
But there's romance too, so it's okay.
Yeah, it's a little background. So,
Yeah.
And then Allison, can you tell us a little bit about yourself?
Sure. So as everyone heard, I live and work in Rochester, New York. I'm a homegrown doctor. So I grew up in the Rochester area and then stayed for my job, which I really, really love. I have 3 kids, so outside of work, I am generally on a sideline, particularly in the spring. I have an oldest son who plays a lot of baseball. My middle son plays a lot of tennis, and my daughter plays softball and basketball. But I also love to exercise, and I love anything to do with my dog.
That's fantastic. Does your dog run with you?
We generally do a post-dinner walk. She's a black Labrador, but not particularly high energy. And a fun fact that probably a lot of people have heard me say if they've spent any time with me is that none of my children are atopic, but my dog is, and she's actually on a biologic.
That's so funny.
That's fantastic. I actually recently was trying to look up something about dog allergies for a patient, and instead it came up with dogs with allergies. And so of course, my Google search comes up on the screen, and we both had a good laugh about that.
Yep, she gets her biologic every 5 weeks.
So both of you have a particular interest in contrast hypersensitivity. What about this topic was particularly interesting to you and kind of got you excited about it? So Carolyn, maybe you can go first.
Well, as you know, these days, CTs are being utilized just about at a drop of a hat for any kind of problem a patient has. And so unfortunately, with the rise of CT utilization comes the increased probability that a radiologist will be confronted with a moderate or severe reaction. And so patient safety is something that I've always been interested in, and contrast in general was introduced to me by my mentors in residency. So I've been doing research in that area, and so the reaction world sort of fits into everything that I enjoy and enjoy researching as well.
What about you, Allison?
So I have an interest in drug allergy, and I've done a lot of work surrounding penicillin allergy. And I was actually the chair of the adverse reactions to drugs and biologics committee when Carolyn was spearheading this contrast task force. And I think contrast allergy is kind of the under-recognized or quote new penicillin allergy, where it is found in a lot of patients' charts. And I think we underestimate the harms associated with that label, similarly to how we approached penicillin allergy years ago. So when Carolyn brought this up, I was really excited to participate because this does come up routinely in the 2 hospitals I cover for our allergy group.
I do like the contrast is the new penicillin allergy, because it's so true. Like we now are well aware of how penicillin allergy is listed in people's charts, that they're not allergic, that it causes so much harm, that they don't get the antibiotics they should get. Similarly, contrast allergy being listed, the harms it can have, we're going to talk about, and that it stops them from getting the care they need in a timely fashion, or they end up getting additional medications that can have harm associated with them. So the new penicillin. I just want to make it clear that when we're talking about contrast reactions, that there's obviously different kinds of contrast. And so in particular, in this episode, we're really talking about the iodinated contrast used in CTs and not other formulations of contrast, just so it's clear. Carolyn, how common are reactions, and what do we know about who's at risk for them?
So overall reactions to low osmolality contrast media is relatively uncommon. They've been reported up to 1.4% of injections, most being mild, but moderate and severe reactions can occur, and those usually range somewhere between 0.2 to 0.01%. And patients who have had a prior hypersensitive reaction to low osmolality contrast media are at the highest risk of having a repeat reaction.
And that sounds like such a small percentage, but if we think about how many contrast scans are done every day, that's actually a pretty significant number of people that will have some symptoms with contrast.
Yes, there's some estimates that the increasing rise of CT utilization is estimated to be about 10% year-over-year growth. So
That's a
you're
lot.
right.
Our CT scanners are busy. And then over the past few decades, the standard of care in the United States has really become just giving people steroids and antihistamines as premedication. Maybe we can talk a little bit about how that became the standard, and maybe the history of contrast use and reactions. Allison, can you tell us a little bit about kind of how that became our standard?
Yeah, so I think this is an example of something that's been carried over for a while in medicine just because it was how it was always done. And the data supporting the use of premedication really comes from the old days where high osmolality contrast media was used. So I think that was before 1995. It might have been even earlier. Carolyn, correct me if I'm wrong. So the data that supported the use of premedication was mostly from studies done with contrast media that's not even used any longer because all studies now use low osmolality contrast media. And the reaction rate for low osmolality contrast media is like tenfold lower. And so we really don't have any good data supporting the use of premedication with the agents we're using now. The thought is that premedication led to vasopenia, and it would prevent sort of that non-specific histamine release that is thought to be the mechanism for some contrast reactions, but there's also accumulating data that some of these reactions may be IgE mediated based on skin testing data, and we all know that systemic steroids don't prevent IgE mediated reactions. So that was kind of a long answer to say that this data is old and based on contrast we don't use anymore.
And is
Yeah,
this
and just
really?
to, oh, sorry.
Yeah, go ahead.
Just going to do the one clarification is that the first FDA approved low osmolality contrast media agent was in 1985.
Okay. But they
I
didn't
was a decade late.
But they didn't start using it right away. My understanding is that it was pretty expensive initially, and so people still held on to the higher osmolality for a little while before we really changed over. Is
Yeah,
that
but just
yeah,
to clarify, because in our recommendations, we do say that if you had a history and you know your allergy was before 1985, then the presumption it's high osmolality because there were none available until 1985. So
very
exactly
fair.
when people started using it more commonly, there was a lag, I'm sure, but we don't want to have that uncertainty area, I think, in our recommendations.
Of course, yes. So 1985, we know if it was before then, it was definitely high osmolality, and the risk of you having a reaction to low osmolality contrast is low. As we think about contrast allergy, I think that it's important to think about how we classify the reactions because it's very different to have kind of a very mild symptoms versus having these more severe reactions. And the ACR handbook does a great job of laying out kind of the contrast reactions very clearly. Carolyn, can you tell us a little bit about how we think about these reactions, the immediate versus delayed, the physiologic symptoms, mild, moderate, severe, so we're kind of all on the same page?
Sure. We label adverse reactions immediate as those that occur within 1 hour, and the delayed as occurring longer than 1 hour, can be even up to days later. And there is a subcategory of hypersensitivity, which are thought to be more allergic like, which does include the bucket of IgE related, versus physiologic, which is more thought to relate to the chemo properties of the agent, more of like a chemotoxic, if you'll say, response to the agent itself. And then within those classifications, we wanted to give some sense of the severity of the reaction. And some of that is guided also on what the outcome of the patient would be. Mild reactions being self limiting, there are no vital sign changes, whereas moderate reactions, also no significant vital signs changes, but there could be escalations of the actual symptoms themselves. And then in contrast to severe reactions, where there are vital sign changes to the patient, and if you don't treat them, there could be some harm to the patient, including potentially death.
And the physiologic symptoms that people have are things like that heat, flushing, kind of their heart racing. Those are the kind of physiologic symptoms we think about.
Mhm.
I
And
think it's
so,
interesting. Sorry, I'm interjecting. I think it's interesting, sort of the terminology gap that we had to bridge between our radiology group and our allergy group. So, radiologists, I think, term physiologic reactions, what allergists would probably say adverse reaction or maybe intolerance or side effect. And then allergic, like, I think we tend to think of as like immediate reaction, either IgE or non-IgE mediated, and then a delayed reaction. So there was a fair amount of discussion about how to clarify that between the two communities, and hopefully, I think we accomplished that in the document.
I think it's good to think about how radiologists versus allergists think about these types of reactions. And clearly, the radiologist is there when there's a reaction, but then often the allergist is asked to weigh in as to what to do, and they're not going to actually be there when the patient receives the contrast. So I think that's the importance of bridging the two fields is there because we need to work together. So love that the task force included both groups.
Yeah, I agree. And I think the radiology colleagues are the ones in the trenches seeing sort of the range of all of these reactions, and we're just hearing about it historically.
And then one of the things that I think is so important in the report is talking about how important it is to document exactly what happened during the reaction. As a radiologist, what is important to see in the chart when someone's had a reaction and they're coming back to you for a scan? What is it that you would like to see documented so you really know how to take care of the patient?
Yeah, I think it's really important to have the details of the reaction because too frequently the patient will get a label of anaphylaxis, but then when you actually ask them what actually happened, they'll say like, "Oh, I just had a few hives on my face," which is not equivalent to anaphylaxis by any definition. But somehow it just gets charted that way, and some of it can be the EMR kind of drives you towards certain definitions inaccurately, or just that's kind of a bucket terminology people sort of assume everything kind of falls under. And so whether or not that person needs pre-medication or what kind of pre-test risk they have for getting another reaction and therefore something serious differs depending on what the initial reaction was. So obviously we need that detail. And then in addition, it's really important for us to know what agent that they reacted to, because some of the literature is suggesting that switching agents is a useful way to avoid a re-reaction. And if you don't know what they had the first time, then you don't know what to switch away from. So those are the kind of main things. And of course, the timing kind of helps you define whether it's an immediate reaction versus a delayed reaction. And then the treatment that had to be instituted, because sometimes the patient is a little vague as to what they had, but clearly if they received epinephrine, it must have been something pretty serious. If they said they got nothing, then it must be something pretty mild. So all of that information can give you more information. And so to figure out what kind of initial pre-treatment, if anything, is necessary for the patient before their next exam.
I was just going to say, the way I've been thinking about this in terms of, I completely agree with everything Carolyn said to document. And just like no one should have a cephalosporin allergy, right? We need to be documenting like specifically what cephalosporin was the issue in order to guide our treatment. The same thing should be the case with iodinated contrast. And there is a document that was published a few years ago. Autumn Geyer is the first author with guidance on electronic health record documentation. And there is a little bit on contrast in that document.
Yeah, definitely. I know that I often have patients, they don't know what they got, whether it was an MRI or even a CT. They don't know what type of contrast. And you ask them what happened, they're like, I don't know. They just told me something happened. And then you're like, I'm not sure what to do with this and how to advise you. So I think that it's important as much as we can go through the chart, get the information, go back to the radiologist or even the tech that was there and can tell us exactly what happened, what they got, can be so helpful. And then, Allison, are there any groups of patients who don't have a history of a reaction who should be pre-medicated?
So my short answer is no. And that's, as we discussed, as Carolyn mentioned earlier, really we base our risk stratification on if patients have had prior reactions, and the important thing is to get a detailed history for those reactions to guide our recommendations for future studies. I think the only type of patient that might give me a little bit of pause is a mastocytosis patient, but I think that would be a patient-centered discussion. So we didn't make specific recommendations regarding that.
Sure. But if someone says, oh, my dad reacted to contrast, or I always have a hard time with medications, those are not the people that need
Those are
anything.
not the people that need to be pre-medicated. And I think sometimes that can be a tough clinical discussion because patients maybe have just done that routinely because people think it's, quote, the safest thing to do. And then I think taking a step back and talking about the harms of steroids and the harms of sort of cumulative doses of steroids, I've certainly had those conversations with patients.
Yeah. So what are the harms of pre-medication?
I think there's pragmatic harms just in terms of like flow. Carolyn can speak to that probably way better than I could. And then there's certainly the risk of adverse outcomes from a delayed study for the patient. So if they have to wait 12 hours or 13 hours or whatever the pre-medication regimen at the institution is, and there's diagnostic delay, then that can be an issue. There is like a study that shows that those patients may be at higher risk for infection. And then, of course, there's short-term steroid effects that I think we're all pretty familiar with. Short-term effects on blood glucose or mood or ability to sleep or fluid retention. But then there's emerging data as well about cumulative doses of steroids over time where, sort of a lifetime exposure to steroids is full of risk in terms of bone health, in terms of cardiovascular risk, in terms of infection risk. So I think, again, this is one of those areas where I think for a long time we thought we were doing what was safest for the patient, and that if this is a way we could possibly prevent a reaction, we should do it. But then you have to look at the flip side of like, what are the harms that we're doing by premedicating and by delaying these studies?
So, what are the harms of delay, Carolyn? I think that there's a study looking at how long the hospitalization gets extended in people who have to be premedicated.
Yeah, so if you want to do this oral premedication, which is usually at least a 13-hour prep, then it requires the patient to stay. Usually, they'll not be able to stay in the ED, so they'll get hospitalized just to wait for this scan. And of course, as Allison said, there would be potential diagnostic delay, which could therefore delay some sort of treatment that the patient could use later. And so I think that those are some concerns, and there is some suggestion, could there be an emergency prep, but that would be at 5 hours, which does shorten some time, but still there is a delay that is built in, and anything shorter than that, we're not confident that the steroid is actually doing anything, and besides, because the length of time of the onset is so short.
And then I think too, like we always, sorry, Rebecca, I was just going to say once more, like I've had some patients who've also had issues where, you know, we all know it takes a while to get studies set up as an outpatient. And then if someone shows up for a study and someone decides they should have been pre-medicated and then their study's canceled, I mean, that's a huge hassle for patients too, and leads to a diagnostic delay that can certainly be clinically meaningful. So I think clear guidelines there just will make it smoother. I mean, we're trying to have clear guidelines here to make it smoother for both the, you know, people working in radiology and radiology staff and physicians, and then also patients.
Absolutely. Carolyn, can you tell us about the data that's coming out about changing contrast and the benefit to doing that when someone has a history of a contrast reaction?
Yeah, so a lot of this data is coming out of Korea and outside the US because other countries have access to all 7 iodinated contrast media agents that are available. Unfortunately for us in the US, we're limited to just 4 agents, so it's harder for us. But there is some data suggesting that switching agents and possibly even being mindful of the side chain related to that iodinated contrast media could reduce the your chances of developing another reaction when re-exposed, and that even the side chains is switching has a stronger effect on the decrease of your risk of getting it than just either giving the same agent or switching to a common side chain. But this is a lot of data coming outside of the US. But there is some limited data also in the US. A large study came out of Mayo that showed this as well. So there is some suggestion that this strategy of switching agents may even be more effective than steroid premedication, although we have to be cognizant that similar to the steroid premedication data, the evidence is still weak, mainly because of the variability across multiple studies and the differences of the switching agents. There's not a standard switching methodology across all the studies to say that this is the best way you go from A to B or B to C. So that sort of puts a caveat on the limitations, but there have been some systematic reviews and meta-analysis favoring this. I think the most recent one would be from Omakashi from the Michigan group, showing the benefits of switching agents.
One thing I didn't understand as an allergist is how difficult it can be for radiology to switch agents. That the way that the contrast is given has this large bottle and kind of a multi-injector kind of comes off of it. Can you, since most of the people that listen to us are allergists, can you tell us a little bit about why is it hard to switch agents?
Yeah, so there are some institutional barriers that your radiology department may be facing in terms of operationalizing switching agents, despite the fact that the data says that it may be beneficial for patient safety. Some of these relate to, as I alluded to earlier, the low number of agents available in the US. And because many institutions are kind of going together as a buyer group to reduce the cost of these agents, this limits what agents are allowed to be on formulary because they get preferred vendor contracts. So, and then some of these agents are 3 times more expensive than other agents. So your hospital administration may not want to have the other agent available. You don't know how many agents to have on stock and then how much of it, because they do expire. And so you don't want to be stocking a lot of these potential agents for potential switches, but then you don't actually ever use them and then they expire out, because that's obviously a negative cost to the institution that they won't want to eat. And then finally, like you said, so there is a push in radiology to move from single injectors to multi-dose injectors. And this is to improve efficiency for the technologists because they don't have to keep switching out bottles, and then that improves patient throughput. So that improves patient access as well because there's increased utilization of CT. So there's a lot of pressure to try to get more patients through the scanners. But the problem with the multi-dose injector is that if you just spiked a bottle and then the next patient you're about to scan needs a switching agent, you have to make the decision, am I going to remove this bottle I just spiked and then waste all of this material? And that was part of the benefits of the multi-injector as well, is that it was reducing plastic waste and reducing contrast waste. So all of these kind of have to be factored in. You can have open ports waiting for the patient that might need switching, but again, that reduces that efficiency you thought you were going to gain by having these types of injectors.
Yeah, especially since we've recently gone through the contrast shortages, I think there's probably a lot of hesitancy for, contrast waste.
Mm-hmm.
Allison, in patients with a history of mild immediate reactions, these mild symptoms, they're self-limited. What recommendations did the group make?
So I think that a great take-home bullet, and this underscores what the anaphylaxis recommendations are, is that for mild reactions, we came out against recommending premedication. And I think that is a pretty big departure from what many institutions do. But I would urge people, if they're going to change one thing based on listening to our podcast today, it should be do not premedicate patients who have a history of a mild self-limited reaction. For moderate, we hedged a little bit. We certainly favored, based on the imperfect data that Carolyn mentioned, we favored a direct contrast switch. There's also some data that not switching may still be okay and patients may tolerate their study, but we didn't want to be radical, and so there's a sort of an asterisk where premedication could be considered based on patient and physician preferences.
Absolutely.
And I would say that breakthrough reactions typically are about the same severity or lower severity of the original index reaction, which is why our algorithm sort of bases it on the severity of the first reaction to guide you as to what to do next. So in contrast to the ones that Allison mentioned for severe reactions, although they are very, very uncommon, of course, they're the most likely group to therefore have another breakthrough reaction that could be severe. And so for those patients, we advise first try to find another imaging study that might answer your clinical question, whether it be an alternative like MR with or without contrast, ultrasound with or without contrast, or non-contrast CT. And after all, you've exhausted other potential diagnostic imaging studies, but you really need this contrast-enhanced CT, then we advise you to pre-medicate and also try to switch agents when feasible. And we, again, when feasible, because we know of those institutional barriers and we didn't want to paint anybody into a corner that they, because of institutional barriers, were unable to get out of.
Perfect. And then one controversial area is the idea of skin testing, that as allergists, skin testing may be helpful in determining, particularly in these severe reactions. Alice, can you talk about when skin testing might be useful?
Yes. So the data surrounding skin testing, much of it comes from outside the U.S., as Carolyn was mentioning, for a lot of these contrast studies. And in other countries, there are more contrast media options. So the studies on skin testing are imperfect because essentially what they do in general is they take all the contrast agents available and skin test patients with a history of a reaction and then try to identify a contrast that is skin test negative for a patient to use. And it's imperfect because we know some patients who are skin test negative are still at risk to have a reaction to an agent that was skin test negative. And then some patients actually test skin test negative to an agent that definitely caused their reaction. So I think that if contrast skin testing is employed, it has to be thought of as an imperfect tool to approach this problem of iodinated contrast allergy. The data is probably best for patients that have had a more severe reaction. It looks like maybe skin testing is more helpful in the reactions that are more severe based on a few studies. And there's some thought that those reactions may be more likely to be IgE mediated based on the skin testing. And there's some data that doing the skin testing within 6 months after the reaction is when it is most helpful to do. So I think on paper, skin testing is a tool to use when someone's had a severe reaction. You have multiple contrast agents that are potentially alternatives, and the patient is anticipated to need future studies. I think practically speaking, it's pretty difficult if someone's institution doesn't have an alternative contrast, which very well may be the case. It can also be pretty difficult for the reasons Carolyn was discussing to actually secure these agents for testing. And so even obtaining the material to test can be pretty daunting. I work for a health system, and it's still pretty difficult to get the material. I can't imagine what it would be like for, an allergist in private practice trying to implement this in their practice. So I think there's sort of, on paper, the right answer of when you would use it, but then practically speaking, it may be fairly difficult to carry out.
Right. And that it also goes back to the fact that we think most of these reactions are not related to IgE. And so therefore skin testing is not a helpful strategy. But in those patients, maybe with more severe reactions who have, more symptoms that we think are more likely to be IgE mediated, they may be the more likely. But you're right, with all of the barriers to skin testing, with obtaining the agents, having multiple options, skin testing to them, and then using the one that's negative, that can be a really difficult for a patient.
And I think, I think the skin testing conversation is when you have the luxury of time. And in many of these cases, you don't. These patients may be hospitalized and need imaging, and delay in care is suboptimal for the reasons we've discussed.
So, if you could do any study that you think would help us to best understand contrast allergy and you didn't have limitations on resources, what do you think would be the most helpful for us to do?
Well, in an ideal world, we would do a multinational, multi-institutional, randomized control trial to have large enough number of patients to have statistical significance in the small subset of patients we actually care the most about, which is definitely the severe patients and possibly even the moderate reaction patients. And we would standardize the agents and the pre-medication regimens that they would receive, because right now there's so much variability. Even there is some data that suggests, there was a meta-analysis, Shea, that said that with patients with prior moderate to severe reactions, he found some evidence that the pre-medication with steroids was helpful at preventing another reaction the next time. But again, it was like 5 observational studies of various countries, and they all used different kinds of steroids, and the dose equivalent was different within and across studies. So that's not great data. So in order to standardize it, we would have to be consistent in all these multiple institutions across all these countries to get that information for us to even see if the steroids are useful at all. And then if we also want to explore the switching agents, then somehow we would have to have access to all 7 agents, and we would have to standardize switching from a certain type to another type, and then this type to that type, so there can be consistency to figure out what was the best switching potential strategy as well.
So challenging to get the perfect data for us to know exactly what to do. So I think that we're using the best kind of data that we have, as imperfect as it is, to try to put together recommendations. Yeah, it would be great to
I
have
think
that.
most of the data we have is retrospective. So I think any prospective data would be helpful. I think, and I agree, because these rates are so low, it's a difficult study, but there also are so many of these studies being done that it's not impossible, but you definitely need an arm that's just switching via a standardized protocol to a standardized sort of progression of agents. And then you'd have to have an arm that is just pre-medicated via a standardized protocol. And then you'd have to have an arm maybe that has both. Because I think it's hard to know what to do otherwise. I do think Dr. Elizabeth Phillips and I were talking informally one day, and I think she had a really good idea of looking at trauma patients prospectively, because a lot of those patients end up getting studies before their history is really known or their identity is well worked out. So there may be pearls of data in that patient population, but again, it'd have to be a big study. But I trust anything that Dr. Phillips says.
Absolutely. And then I definitely want to take the opportunity to dispel some of the myths about contrast that continue to abound. Allison, is seafood, particularly shellfish allergy, a risk factor for contrast allergy?
It is not a risk factor. This is another one of those sort of myths in medicine that is refuses to go away. There's even a paper that shows sort of in our model of medicine where knowledge is passed down from mentor to trainees. This is sort of a nugget of information that survives. But I'm here to tell everyone that it should not survive. There's no reason to be concerned about a contrast reaction in people who claim to have a shellfish allergy.
What about an iodine allergy?
I don't even know what an iodine allergy is. It is an element that we need physiologically. So that's also potentially born out of maybe a reaction to a topical iodine agent, but also not a risk factor for a reaction to contrast.
I think it does come out of this 1970 study that identified, food allergy as a possible risk factor. And of that, because shellfish allergy is a common allergy in adults, there was this association made. And then in the kind of discussion, it talks about iodine. I think you have to go back and get the microfiche to see the paper. But I wonder if that is where it has gotten kind of passed on down through.
No, I think that is the basis. Yes, that's the historical context, but it has been, it's disproven, but it still is on so many questionnaires for, intake forms for healthcare systems and, radiology clinics.
Yeah, so if anyone out there listening has it on their form, we would urge you to have that taken off because it also confuses patients and then they start associating it in their head. And then do patients with a history of asthma, food allergies, medication allergies, or kind of any history of allergy, did they need to be premedicated?
They also did not. So we make a strong recommendation regarding sort of pre-existing conditions. There's not data linking those conditions with an increased risk of a reaction. So those patients should not be premedicated.
And then if I have an allergy to iodinated contrast, or I've had a history of a reaction to iodinated contrast, how does that affect my ability to get other contrasts like gadolinium?
It has no effect. We only care about in-class prior reactions, and the two chemical structures between iodinated contrast media and gadolinium-based contrast agents are not similar. And there were some small studies that had suggested some linkage, but in these studies, if you look at the science, they were self-reported quote unquote allergies that the patient was reporting. And some of them were like skin site irritation of where they got injected. So there was a lot of conflated information inside there versus true allergy there's no chemical or reason for there to be any sort of cross reaction between these very distinct drugs.
Yeah, no, thank you so much for helping to dispel those myths. We'll hope to continue to try to get them strict from the people's passing down of knowledge. And just in terms of take homes from the recommendations from the paper, what are the things you really want to make sure that people kind of take away?
Mine is what I said before, where we should absolutely stop premedicating for reactions that are clearly mild in nature. I think recognizing the value of switching contrast is also important because I think that's a concept that many people are unfamiliar with if it's feasible. And then lastly, with contrast allergy being the new penicillin allergy, make sure you're documenting the specific type of contrast. It's included in every radiologic report, so we need to take responsibility for cleaning up the electronic health record allergy field, and this is one area that has a lot of room to improve.
Yeah, and I would just add lastly, to kind of break all those myths, for example, you do not need to premedicate for any chemotoxic or physiologic prior reactions, in addition to the ones we mentioned with the shellfish, the quote-unquote iodine, or topical povidone prior allergies. You do not need to premedicate for any of those, or gadolinium.
So I just want to encourage everyone to read the paper and to keep it as a reference. It's a great paper with these beautiful tables that really help to delineate mild, moderate, severe reactions, as well as non-allergic reactions. It talks about anaphylaxis versus a vasovagal reaction, which sometimes gets mistaken for anaphylaxis. It reviews all the evidence, including all these papers that were discussed today, that all the evidence that we have and the strength of the recommendations. And so I think that it's a really important read for all allergists and radiologists, just given how frequently we encounter this. Is there anything else you guys would want to add?
I just want to recognize Carolyn for her tireless work on this document. She was a fantastic leader and really persistent in making this the high quality document that it is. And also, Rebecca, I want to thank you because your contributions were equally impressive. So thank you for your help. You didn't really get to share your knowledge because you're the interviewer, but it was lovely to work with both of you and the rest of the team.
No, I love the fact that it's a multidisciplinary group. I think that's so important.
Yes, I also thank you, Allison. It's very nice of you to have such nice, kind remarks, but it was really a group effort, and it was, I think, born from recognizing there was a divide between what was out there in the allergy literature with the 2020 practice parameters, kind of recommending no steroids at all, and then what the radiologists were still recommending and doing, which was pre-medicating for basically all allergies. And so that was a very large bridge divide, and to find some way to get to some consensus that was agreeable, because we know that the evidence is weak, but the absence of evidence is not the evidence of absence. And so keeping patients at the forefront of what we're trying to do to try to be patient-centered and protective of them, as well as trying to break these long-held beliefs that were weakly held with science. So I think that was a fine line for us to walk, and I'm hopeful that our product will move everybody forward in the management of these patients with prior reactions to contrast, or specifically iodinated contrast media.
Well, thank you both. We hope you enjoyed listening to today's episode. We want to thank all the members of the task force, of course, Carolyn Wang and Allison Ramsey, who are here with us today, as well as David Lang, Anna Kopascu, Marilyn Kuravilla, Jeffrey Newhouse, Benjamin Mervick, Pranay Krishnan, and Elisa Sumkin. Thank you also to Troy Williams from the ACR who helped with the literature review. As a reminder, this podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any questions about one's own health should always be discussed with their physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists in your area. Use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at quadai.org. Please visit quadai.org for show notes and pertinent links from today's conversation, including a link to the paper. If you like the show, please take a moment to subscribe to our podcast in whatever podcast app you use so you can receive new episodes in the future. And we always appreciate feedback, including topics you're interested in hearing about. Thank you again for listening.